Start with a case. We have a 69-year-old male with metastatic prostate cancer to the bone who presents with worsening fatigue and is found to have profound neutropenia. He does not have any signs or symptoms of infection. He is on hydromorphone as needed for diffuse pain. He is about to be given pegfilgrastim, Neulasta, and the hem-onc fellow asks you to order something for his pain. Which of the following medications might be good for his bone pain? NSAIDs, acetaminophen, loratadine, A and B, or A and C? So I'll let you think about it for 20 seconds and pick one. All right. So I'm going to make the argument that it is NSAIDs and loratadine. So we have to talk about filgrastim, which is Neupogen. So filgrastim stimulates the production and release of neutrophils from the bone marrow. And so it is a G-CSF, granulocyte colony stimulating factor. And it is cleared by the kidneys or by neutrophil-mediated phagocytosis. And this mechanism of clearance is going to be very important to understand. Because pegfilgrastim, which is Neulasta, I think the name was because it lasts a while, is pegylated. And so pegylation is the process of conjugating a molecule with polyethylene glycol. And if you add this pegylation, the kidneys can't clear it because the molecule is too large. So what does that mean? It keeps stimulating the bone marrow to make neutrophils until there are enough neutrophils to clear the medication. So this is pretty ingenious design. So Neupogen is given daily, Neulasta is given once. So what does this have to do with bone pain? Well, giving G-CSF can cause bone marrow expansion, which is quite painful. Imagine putting an IO in someone and injecting fluid. So this expansion occurs primarily through a histaminergic response. So a trial was done, Nolan, naproxen or loratadine and Neulasta trial. And it was a randomized phase 2 study. It estimated the effect of prophylactic naproxen or naproxen, whatever you want to call it, or loratadine versus nothing. And the percentage of patients with all grade bone pain in cycle 1 from AE reporting in the naproxen, loratadine, and no prophylaxis groups was 40, 42, and 46% respectively. Differences between the treatment groups were not statistically significant. So not that big of a difference, but it is better than absolutely nothing. So compare that to giving something like more opioids, right? So just to recap G-CSF-induced bone pain, you have to ask yourself, is it cleared by the kidneys or cleared by neutrophils? Filgrastim, which is Neupogen, is cleared by the kidneys and cleared by neutrophils. Pegfilgrastim, which is Neulasta, is not cleared by the kidneys, but is cleared by neutrophils. So the act of pegylation allows this to keep acting until the neutrophils phagocytose the molecule. Pegfilgrastim causes bone marrow expansion through a histaminergic process. So you should consider using loratadine or naproxen for G-CSF-induced bone pain. And that's it. It's an even faster facts. Thoughts, comments, questions?
I was gonna say, I think thanks for showing the data, because I think I had only anecdotally heard about it and was like, it should always work was kind of what I had been like unofficially told. So it's kind of interesting to see that it's pretty minimal, but is obviously probably worth giving in these people.
We have a question at HPACT. It's Marielle. So would the loratadine help for both filgrastim and pegfilgrastim or just pegfilgrastim?
It should theoretically work for both.
Okay.
Yeah, so here it says pegfilgrastim, but really both of these will cause bone marrow expansion. Great question. And then it looks like Dr. Plotkin has a question. Any other histamines we think about? So no one else has studied anything else, which is kind of weird. I don't know why they picked loratadine and not something else. And then Dr. Rapetti is saying, Holly and I are wondering why loratadine works. So it's all through the histaminergic process, and I don't know why they haven't picked another antihistamine. All right, thanks all.